Good morning. Welcome to everybody to my series of lectures on anesthesiology. Today we'll discuss a very important topic of anesthesiology, that is positioning of the surgical patient. Proper positioning of the surgical patient is critical. Positioning requires a range in the severity from minor skin abrasions to the peripheral neuropathies, non-healing pressure ulcers and blindness. Overview. Proper positioning of the surgical patient requires a careful balance of optimal surgical field exposure without subjecting the patient or inappropriate positioning. Each surgical position, that is supine, prone, lithotomy and lateral, presents its own unique risk and challenges. Knowledge of potential positioning complications and their timely recognition and management are critically important for a successful outcome of any surgical procedure. Factors affecting positioning. Complications arising from patient malposition during surgery depend on both non-patient and patient factors. While most of these factors, as for example, type of the procedure, patient's age or gender, cannot be modified, recognition of patients who are at additional risk for positioning complications should alert the anesthesia provider to take extra precautions. These patients are typically 70 years of age or older, morbid obese, that is BMI of more than 40, thin, small in stature, have a poor preoperative nutritional status, or a history of diabetes or vascular disease. Now, general positioning guidelines. Proper positioning of patient balances the need for adequate exposure of the surgical field and prevention of positioning injury. Risk factors associated with the positioning of the patient. Non-patient factors. What is non-patient factors? Like type of procedure, length of procedure, type of anesthesia, equipment affecting the patient's position. Patient factors like patient's age, patient's height, patient's weight, nutritional status, deconditioning, other pre-existing condition. Optimal positioning is achieved when adequate arterial supply and venous outflow are maintained to all the body parts. Nerves are protected from undue pressure or stretching. Bony prominences are padded. Circulatory and respiratory systems are minimally compromised. Maximum surgical field exposure is achieved. Positioning guidelines. Supine. Used for abdominal, pelvic, open heart, head and neck, and most extremity surgery. Padding should be applied to the heels, elbows, knees, spinal column, and occiput. To avoid pressure alopecia, periodically rotate the patient's head, especially during the prolonged cases. To avoid brachial plexus injury, upper extremities should be abducted to less than 90 degrees with hands and forearms in supinated or neutral posture. IV tubing and stopcocks touching the skin should be padded. For the tender mark position, considering mattress, you have to use a non-sliding mattress. It is recommended to prevent the patients from sliding cephalite. The tender mark position may cause cardiovascular and or respiratory compromise. Patients may develop edema of the face and upper airway. Prone. Used for posterior spine, skull, buttocks, and perirectal and lower extremity surgery. The patient is typically placed in the position by log rolling after being anesthetized. The patient's proper body alignment should be maintained while turning the patient from supine to prone with special attention to breast, male genitalia, arms, and legs and cervical spine. The arms are usually kept at less than 90 degrees. The eyes should be free of pressure and checked frequently to avoid stress on the cervical spine. There should be at least 2 finger breadths between the chin and the chest. Lithotomy. Used for gynecologic and urologic surgery. When placing the patient into and out of this position, both the legs are moved simultaneously to prevent the torsion of the lumbar spine. The hips are flexed 80 to 100 degrees from the trunk and the legs are abducted 30 to 45 degrees from the midline. Lower extremities are padded to prevent the compression against the stirrups and injury to the common peroneal nerve. Hands and arms should be positioned away from the bed to prevent crush injury during manipulations of the foot section of the OR table. This position can increase the intra-abdominal pressure, resulting in impeding venous return to the heart. Now we come to the end of this session of my lectures. Next day I will come with the continuation of this chapter. Thank you.